It is 11:15. Please take your seats, ladies. All right, let's give it up for DJ Cold Blue. Keeping us entertained. That's right. All right, we're going to keep it moving for the second half of the conference. Got a lot of great things lined up. We're going to introduce to the stage right now from board certified cardiologist of Cardiovascular Solutions of Central Mississippi, Dr. Fakaridi. Give it up, ladies. We got a man in the house. Testosterone. Come on.
Wow, that's an introduction. Good morning, y'all. How y'all doing? Good. Can y'all hear me good? Good. I'm good? All right. Good. First of all, this is the most turned up talk that I've ever given because a hot DJ, a room full of women who know their stuff, educated, informed, about to get transformed. So it's only right that I come and shed some light as to what's going on with not only your hearts, but the hearts of your loved ones, and the hearts of your community, and the hearts of the patients you treat, but also other body systems that emanate from the heart, your cardiovascular system. So it's an honor to be here. I thank you for the privilege of invitation. To all organizers, to all sponsors, thank you very much. My name is Felucio Fakaridi. Origin of the name is Nigerian. Place of birth, Nigerian. Place of growing up, New Jersey, New York. Place of schooling, New York. Site of service, Cleveland, Mississippi. And my why in life is to reduce amputation rates in the Mississippi Delta by 25%. So how did I end up here in front of you today? You have to understand the prevalence of cardiovascular disease. What is it? How it affects y'all in this room. You are the most underappreciated, underdiagnosed, underrecognized, and undertreated group of people when it comes to the cardiovascular space. Why do I say that? Women are a minority when it comes to research studies that are done in the heart and vascular space. Minorities, both Hispanics, Native Americans, and African Americans are the least studied groups when it comes to research and when it comes to protocols that are initiated for therapy, for treatment, for guidelines. So how come when you go see a doctor or a nurse practitioner or any provider in the community, you are given a prescription of a medication that most of y'all were not even included in the studies? Do y'all know that? Can someone guess what percentage of women are included in all cardiovascular studies in America? Can someone guess? Percentage-wise. 5%. Less than 10% is the correct answer. So everyone is correct. Less than 10%. Correct. Now, let's go minorities. Okay, that's the answer. You're right. So the reason why I'm here is because it doesn't mean, I'm not standing here to say that you should ignore your medication and not be compliant. You have to be informed as to why you are under-recognized when you go to, or under-treated when you go with a complaint. But you also have to recognize what are the risk factors that are killing people around you or that you yourself are at risk for having. Now, how many of you know the #1 risk for cardiovascular death in America today? Can someone guess? I'll take numbers. What is it? You said heart disease. Okay. I like that answer. I heard diabetes. I heard obesity. Someone said hypertension. Okay. Hypertension is correct. All right? The second is hyperlipidemia, high cholesterol. The third is nicotine exposure. If you smoke, if you dip, if you chew. The fourth is diabetes. The fifth is obesity. And the sixth, we can add alcohol and drug use to that. But the question becomes, what is cardiovascular disease? Because everyone just says heart disease. I heard heart disease. Cardiovascular disease is a culmination of coronary artery disease, which is the plaque buildup in the heart, peripheral artery disease, which is the buildup of plaque in your legs, arrhythmias, irregular heart rhythms, which is the electrical conduction system of your heart being irregular, congestive heart failure, fluid buildup in your lungs, right? You've heard of that. And then pulmonary embolism, clots in your lungs, is part of the cardiovascular spectrum. The veins get affected. People who have congenital heart disease, you were born with a hole in your heart or a defect. And then people who have, aneurysms, that too is all in the spectrum of cardiovascular disease. The constellation of that is 1 in 3 deaths per annually. So 1 in 3 women will die every year from cardiovascular disease, not just coronary heart disease. All right? So we have to understand what that entails before we can carry this conversation. And underlying and underpinning all the risk factors for this is what? Atherosclerosis, the buildup of plaque, cholesterol, and fatty cells in your arteries that narrow your blood vessels. And if they narrow to a point where you don't have rich oxygen blood going to your heart, you get what? A heart attack. If you don't get it going to your neck, you get what? A stroke. If you don't get it going to your legs, what do you get? Poor circulation, non-healing wounds, amputation, right? Where's the amputation mecca of America? Between Tunica and Vicksburg. Between Tunica and Vicksburg has the highest amputation rates in America. Why? Everyone says God did. Why? Well, I mean, this is family now. We're all family in here. So why is that? Well, I heard non-compliance, and let's park that aside.
Education.
Thank you. They don't know any better. Let's just keep it simple. That's why. Because if you understand that 90% of heart attacks could be prevented, or 90% of amputations could be prevented or treated before they get amputated, or if they sought out a second opinion, that's being informed, right? So education is the key, and that's why we're all here, and that's why I credit all of you for coming and putting your Saturdays aside and listening to hot music and getting informed, right? So education, awareness, and advocacy are the 3 words I want you to take out of today's talk. Education, awareness, and advocacy, all right? So let's get educated more on cardiovascular disease. Every 30 seconds in America, a leg is amputated due to peripheral arterial disease or diabetes. You don't know that. Peripheral arterial disease is the most common, most prevalent, most deadly, most costly cardiovascular disease of all diseases that most of y'all have never heard of till today. Only less than 20% of the whole country have heard of peripheral arterial disease, and that includes medical providers. But it costs us $400 billion a year. As an African American, male or female, your chances of getting amputated is 3 to 4 times your non-African American counterparts, right? But if you live between Tunica and Vicksburg, that chance is about 28 times higher. Okay, why? We are in the cardiovascular epicenter. Diabetes, high blood pressure, high cholesterol, to nicotine exposure. How many of y'all are providers in here? When any patient walks into your office or clinic, you always ask, do y'all smoke, right? Not until I moved to Mississippi did I know that that is a failure on our parts. We were taught wrong in medical school. That should not be the question. Do you know what? Thank you. Because most of our folks do what? They don't actually smoke. They dip, they chew. That is nicotine exposure. So when they go and enroll these people in national trials, there's big companies that spend big dollars. Guess what's not included in that questionnaire? Do you dip or do you chew? When they come in complaining of leg pain or leg soreness, or my leg gives out, my feet is burning. Not my leg is hurting, my feet is burning. I've been rubbing that alcohol on my feet, right? And it's due to the gout. It ain't the gout. It ain't the gout, y'all. It ain't the gout. Let's keep it real now. Because providers, they'll present, oh, it's the gout, let's do our medication. No, it's not. Let's not fool ourselves now. It is poor circulation. You know why? Because mama got the sugar. It's diabetes. That's the nut. Exactly, it's the sugar. So you have to use the words at their literacy level. So what am I talking about? Educational awareness. That's the problem. That's why we have the amputation mecca here in Mississippi. So it's about knowing not only the physicians that are available. I don't know if you know this, but Mississippi has the lowest number of physicians amongst all other states in America. What's also funny about Mississippi is that, let's look at the demographic. It's a 35%, right? African-American population, majority of which are in the Delta. Historically, you have to know the history of Mississippi. We have to address that. People need to get comfortable talking about statistical discrimination. Have any of you heard that term before? Okay. Statistical discrimination, for people who don't know, and I know there are people who are our Caucasian counterparts in the audience, their family, some of them work for me, some of them are patients of mine, and we talk truth to power. What is statistical discrimination? The chances that when you walk into my office, and if you come in with a non-healing wound and ulcer, if I had treated your mom or your dad or your grandfather with an amputation without even shooting dye down that leg to treat him or referring them to someone who can save that leg, if I treated him that way, your chances will be the same preconceived notion and therapy that I prescribe to you. So it's based on preconceived notions of how I treated someone that shared similar characteristics as you did. So that's why it's important to have a multicultural team when you set up a team in the healthcare field. Doctors, we need more doctors who represent and look like the community they treat. We need more nurses who represent and look like the community they treat. We need more pharmacists who represent, more psychiatrists, endocrinologists, podiatrists, wound care centers, infectious disease doctors, pulmonologists. They all need to look like the community they treat. I do not want to walk into any society in Mississippi Delta and see just a room of homogeneity. Because then it deeps into how you interact, how you educate, how you talk to someone, how you seek compliance from them. Gaining the trust of a patient is the most important thing, right? How can they trust what I'm saying? How do they trust that when they come to my office, you get not access to care, but access to quality care? That is the key. So how do you do that is you engender the trust of the population of the patients that breeds care-seeking behavior. They want to come back and see you. They want to come and ask you questions. Even if it's not related to the heart, they will ask. They want to take the medicines you give you, or they'll tell you why they couldn't afford that medicine, which is another important topic, because people get uncomfortable talking about the social determinants of health. Transportation, right? That's important. No offense to Jackson, but why do folks in the Delta gotta drive 2 hours every time to come to Jackson or Memphis? No offense. I'm an outsider who just noticed all of this by moving here 4 years ago, because they lack the multidisciplinary teams that should be in the Delta to treat the epicenter of cardiovascular disease, right? So let's talk about education. Why are we not doing much to educate our young kids about why it's important to lay off that sugar? Sugar is the new tobacco. Sugar is the new tobacco. You gotta watch that. 1 in 3 adults will be a diabetic in the next 20 years, right? People are surprised. 1 in 3 adults have hypertension already, all right? But 1 in 3 adults will be a diabetic. Why? How many million people are pre-diabetic already? There are about 60 million people that are pre-diabetic. About 30 million people have diabetes. If you look at the most chronic medical conditions that exist today, the number one is actually venous disease. Venous disease is problems with the veins. I'm not going to go into that topic today because y'all will just flood me with questions. The second is diabetes. The third is peripheral artery disease. 20 million people have PAD. Only 12.5% have been diagnosed. So I want to talk about that. You know why? Because it's costing us $400 billion a year. It's killing our folks because after an amputation, after every 30 seconds, remember that word, every 30 seconds someone gets amputated. After an amputation, 80% of them are dead within 5 years. Okay? All right? And they die from heart disease. So people will say, oh, they have heart attacks. No, it's cardiovascular disease. PAD, it's in the leg, it's in the heart. What are the risk factors? They're the same. So we went to Washington, D.C. in September, and we gave a talk to Congress about this, because I believe in advocacy. You don't walk the walk, you talk it, and you live it, and you become the voice for the voiceless. And this was the presentation where we talked about a woman who walks into my clinic who was told that she was just diagnosed with breast cancer. Every woman in here fears that word cancer, right? Imagine if you were told you had breast cancer today. And look at what's your 5-year death rate from a newly diagnosed breast cancer. It is a third of someone who was just diagnosed with peripheral arterial disease. Your death rate from PAD is 3 times higher than someone who's newly diagnosed with breast cancer. The end stage of PAD, which is critical limb ischemia, which is when you have these non-healing wounds or ulcers in your legs, gangrene, that is equivalent to pancreatic cancer. Okay? So, it's more prevalent than all cancers combined. I told you that. It's more costly than all cancers combined. It's least aware of all cardiovascular diseases. It's progressive. It's asymptomatic or atypical, meaning patients do not come in saying, hey doc, my leg has been hurting when I walk and it goes away when I stop. No. Subtle symptoms. You all know people who have the sugar or diabetes, right? They'll tell you like it's burning, it's tingling, it's, who are at risk. Anyone over the age of 50 who has either history of diabetes, high blood pressure, high cholesterol, who's had some nicotine exposure, or who's had a family history of peripheral arterial disease, or any other history of atherosclerotic burden. You've had it in your heart, you've had coronary disease, you've had a stroke, you've had kidney disease. You should be screened for peripheral artery disease. All right? So understanding who are at risk is very important, because that's how you start at least thinking about what are the possibilities other than the arthritis that you're told, or neuropathy, or the gout, as I said, right? So we need to know and we need to fear this because of the clinical, economic, and human impact. All right? Now, it's a lottery. Where you live determines if you live. What you look like determines if you live. Your insurance determines if you live or die in America. You live in the South, we are at the highest risk of death in the South than any other place in the country. If you look like a black person, you're more likely to die or lose your limbs. Medicaid, Medicare over private insurance, you will lose your limbs. Poor, you will lose your limbs. You live in Mississippi, Alabama, Louisiana, West Virginia. That's an outlier. It's not the South, but the nicotine exposure and diabetes is very common there. People don't know that. Arkansas, Georgia, South Carolina, Louisiana, Tennessee. All right? So we're all in this. This is the rates of amputations in America. Look at the lowest revascularization rates. I've circled them. It's us. All right? So how can a young gentleman, and I say young because I'm seeing them in their 40s and 50s now come to my office who've been amputated. The cost of an amputee, to take care of an amputee in a year, is about $200,000. The lifetime cost is close to about $800,000. How much do we make? What's the median income here in Mississippi? It's $36,000, right? I think I'm right, $36,000 or $37,000. So how can they take care of themselves? That's why our life expectancy is the lowest in the country. This is what Washington needs to know. They're bickering over a wall. These are real problems. So I have permission to share this story, by the way. These are two women who are like mamas to me, and they're patients who I met. One is Miss Campbell. Miss Campbell was, first postmaster in Mississippi, in Starkville. I'm sorry? Gertrude, right. Well, and I didn't want to use her first name, but, she came to me because she heard one of my talks at the church. And she had been diagnosed with diabetes at age 50. She had poor circulation, numbness, tingling, pain. ignored, told it was arthritis. Arthritis. She walked into my office 3 years after she lost her limb. Got amputated at the hospital. She went in there, it was too late. She ended up losing that limb. And it could have been picked up at different stages if awareness, both on the provider side and the patient side, were heightened. But it was not, because they didn't know any better. And so when she walked into my office, the day she walked in because her stump was not healing, but she had her sock. You see the black sock in between. That sock was on this other foot. And one thing when you walk into our office is socks off. I don't care what you come to see me for, because I'm very passionate about this topic. The difference between your socks on or off is life or death. As soon as she took off her socks, I saw those toes, and it's very hard for doctors to get emotional during office visits, but when you see that, and you know the outcome. You know the outcome. There's nothing, I tried. I took her to the lab, we shot dye down her legs. It was too late. Within a month, she lost both limbs. This is her best friend, Mrs. Hughes. They've known each other since 7th grade, all right? Mrs. Campbell cooks for Mrs. Hughes every week. Mrs. Hughes is a military wife. Her husband served our country for 40 years, so she did serve as well. They lived in Virginia. While in Virginia, she had diabetes, and then she had a stroke. When she had the stroke, she could not walk, and they attributed everything to the stroke. So guess what? We had an event, we brought her in, we screened her, and we found out that she had poor circulation, just zero blood flow to her legs. We opened her up within an hour. This took an hour, and this was her in my office the week after. So the problem, and we thank God for that screening event, and we thank God for being able to screen. But the moral of this story is that 2 best friends, 2 lives, 2 outcomes, right? But guess who still cooks every week for her best friend? She misses dancing. She still dances in the wheelchair. She's mama. She followed me to DC. That's why this presentation was given with her in the audience. Miss Hughes couldn't make it. But we have to engage our patients, because I've realized that we always talk to providers, but we need to start talking to the community. Direct-to-consumer approach is what works. I'm done. I'm tired of just saying, let the doctors figure it out. Because guess what? PAD has existed way before all of us were conceived. Oh, guess what? It's becoming a pandemic. 20 million people have it here. 200 million people have it in the world. 160,000 amputations a year. This is a problem. Majority of them look like everyone in this room. So what are we going to do about that? We're going to be aggressive with screenings. Screenings work. This graph just shows what we've accomplished in 4 years. Before I started doing cases at the hospital where I do my cases now, they had 56 amputations in 2014, and they had 0 angiograms. Angiograms are just basically me taking you under an x-ray and just shooting dye down your legs and seeing, just like I did, Ms. Hughes, seeing the roadmap, seeing if you have any blockages. And if you have any blockages, you just unclog it, just like what a plumber would do if your kitchen pipes were clogged up. Roto-Rooter, clean it out, the window open, case closed, all right? So in 2015, we did 73 decreased amputations, went down from 56 to 20. In 2016, amputations went down to 10, and last year we went down to 7 in that hospital. Decreased it by 88.7%. We were just published at one of the largest cath lab digests, which is our biggest cardiology cath lab journals. And the moral of the story and what I told them in terms of our algorithm, the first thing is that you got to treat every patient like a family member. Because if that's your mom or your dad, well, guess what? I'm going to do everything I can to advocate for them. You want to be the voice for the voiceless. But also you have to talk about prevention. How do we prevent ourselves from ending up like this? So I hope you guys have, I guess in this brief time, I've told you about risk factors. I'm not going to harp on them. But now, what do we do moving forward? How do we screen for it? There are things in your offices you can do, ultrasounds of the legs if you suspect, check your patient's feet, their pulses, check their skin color, check their toenails, see if they're normal or abnormal, right? Hair growth. And then what do? You do either ankle brachial index, which is the ABI test, or an ultrasound, or though you refer them to a specialist who you know has good numbers. Now, let me be clear on that. They don't all have to come to me. I'm not here for y'all to say, well, send all your patients to me. No. I'm here to preach about access to care versus access to quality care. If your doctor cannot show you numbers, like this is what I've done, then seek a second opinion. That's simple. Believe in that. And that should go to what's in your non-cardiovascular care, your OBGYN care, whatever. You just want to have good quality care. Outcomes. People are not dying when they go see that doctor, right? That's what you want. People are not losing their limbs when they go see that doctor, right? People are coming back to see this doctor and singing their praises as to how they changed their lives. So if you have high blood pressure, let's talk about the normal high blood pressure. Salt intake, we have to cut it down. 1.5 teaspoons a day. They're like, how do I measure that? Gotta cook it. Stop eating out loud. Cook it. 1.5 teaspoons a day. Okay? If you have sleep apnea, it has to be diagnosed. Pulling the hogs, snoring. You feel tired after a long day, right? And you're like, wait, I slept for 8 hours, I'm still tired. Excessive snoring, you just feel fatigued, headaches, you just feel cranky all the time, right? That has to be addressed, all right? You have to make sure that you get a sleep study, because if you get a sleep study, it decreases the medications you have to take. You get more oxygen into your system, and then you can walk more, lose weight if you want to, or less medicine prescribed by the specialist. Do not believe all the blood pressures that you see when you walk into my office. My office is the worst place to get a blood pressure. Why? You waited for how many minutes or hours, they rush you, take vitals, wait, put you in a room, and then they document it, right? No, go home and document your blood pressures for a week. Morning, afternoon, night. Get a good blood pressure cuff. Make sure it's calibrated by your doctor's office. All right? And that's how you start being, you take ownership of your health. Because that's one less medicine prescribed for that one single abnormal reading that you might get in the office. Diabetes, sugar, got to cut it down. They say 3% of your daily intake should be carbs, right? Should be sugar. Well, this is what I say. Just cut out everything sweet. Tea, sweet tea, yep, we're going to get rid of it. Boom. I know, don't shoot me, y'all. Everybody stay quiet for a second, like, let's talk about this. Moderation. That's the word. Right? Drink more water. Like, it's not that hard. I'm serious. Just drink more water. If you have a sweet tooth, guilty of that. My mom is a diabetic. I lost my grandma to diabetes at age 62. I understand my risk. So I drink water. I don't drink coffee. So once in a week for like a 1 hour period, you might catch me with a Diet Coke or something like small, just because I need to stay awake. But that's once in a week. I'll take that. Otherwise, it's water. All right? Moderation. You got to keep it real with your patients too. All right? So moderation. 2, high cholesterol. Check your lipids. Check your thyroids. Women, the TSH is very important to know. All right? You guys will get your pap smears and what have you, but you need to know what your TSH numbers are. All right? As women approach menopause, perimenopausal symptoms, estrogen, we lose that benefit of estrogen being protective against atherosclerosis and heart disease. So they start getting symptoms that we consider microvascular disease, the small arteries in the heart or in the legs, or other vessels. And so you need to see a specialist who knows how to treat women in microvascular disease. And you need to work in conjunction with your OB or OBGYN as to what therapies, non-estrogenic therapies are available. And then you also have to know your family history, okay? Diet and exercising are very important. That's the key, okay? You address diet and exercising, you address a lot of issues. I tell people you exercise vigorously for at least 150 minutes a week. You decrease your chances of a cardiovascular event by 90 to 98%. Full stop. Drop the mic. That's you. That's not me. That's no one. That's you and the man upstairs, also God, right? So, just wanted to use this opportunity to talk to y'all about this. I don't want to flood y'all. Y'all had a good night. Some of y'all are still trying to recover from last night. Stay hydrated. I see your eyes. I want to take some questions. How am I doing with time, y'all? Moderator? Out of time?
You're out of time.
I'm out of time? Oh, I'm done. Okay, good. I'm done. Any questions?
Take a few questions. We want to look at you just a little bit longer. So go ahead. Good Lord Almighty. Ain't God all right? Ain't the Lord all right? Yes, Lord. You take as many questions as you want. Go ahead.
I am red in the face, and y'all can't tell.
I got it.
All right, who has questions? Any questions? Yes, ma'am. Yes, ma'am.
So, and this is coming from a patient side.
Mm-hmm.
So oftentimes, as a patient, you arrive in your doctor's office, you're already freaking out. Like whatever doctor you're seeing, you're already freaking out. You Google diagnose yourself with everything under the sun, and you're stressed, you have anxiety, and sometimes you come in with a history of dealing with other doctors with bad bedside manner.
Correct.
So you don't trust them.
Correct.
You're already on edge.
Correct.
How can you, in that state of mind, try to be focused enough during your visit to try to think through what the doctor's saying, ask the right questions? Even sometimes you feel pressured with time, like you've got these questions in your head. The doctor doesn't have a lot of time.
Right.
For you, and
You're absolutely right.
It's just, you can kind of freak out. So what would be your suggestion for patients to be a better advocate for themselves in that type of context?
That is an excellent question, First Lady. And I do submit to you that one of the worst things that we do as physicians who own practices or what have you is that we're controlled by people who wear suits all the day and who have no idea as to what it is to run a practice, right? People who determine the time that it takes to see a patient and to really go through their history and take that time, it's absent. So when I walk into a room, it's like, all right, I'm relying on what my nurses told me is going on with the patient, and then my 5 minutes or 10 minutes with you. But then what we try and practice, especially in our practice, is I try and leave the room to leave my nurse with you, so that, because sometimes what I say just, so that moment comes with the nurse. Nurses are what keeps a practice going. I have no qualms about saying that. They are what makes us look good. So nursing is very important. Take advantage of the support staff that clinic has, not only during that visit, but afterwards. Make a phone call. When we give you a card and say, this is who I am, a doctor, every doctor should have a voice message service, or someone that you can follow up with, because you earned that right. It's the day they swiped your copay or your charge, like, y'all in that marriage together. So I can call you like 100 times, like, listen, I have another question. and we need to facilitate how that is. Personally, I think that we, especially in underserved areas, what I would like is an opportunity to have events like this where you can just stand in front of a room and answer questions, like a town hall session. Politicians do it. Why don't we, medicine, I challenge my colleagues to do that. How many cardiologists do we have between Greenville and Clarksdale? Let everyone come out and give talks. Talk to your patients. Go out and reach out to the community. I mean, it's just a challenge. Let's see how many take it up. But it's engaging the community, going to their churches to talk to them, going to the community centers, because you're not going to get everything in that visit. So it's okay to call after your visit. Don't just say yes or yes, ma'am. That's the least favorite word I like to hear, because when you say yes or yes, ma'am, it tells me you had no idea what happened. Question. Don't get fooled by the white coat. I do not wear a white coat. Anyone who knows me knows that. And I do that for a reason, because I really want you to see me as an equal. All right? So that's the best answer I have, is take advantage of the nurses, the aides, the techs who work in that clinic, and then have either the doctor call you back. once you've settled yourself at home to ask those questions. And then, you know, come to your follow-up visit, and hopefully your follow-up visit, just be honest with them. Like, there's a chance that I'm not going to remember my questions or my concerns. Is it okay if I call you back? That's it. Other questions? Yes, ma'am.
They advertise testing, free tests for $99.
Uh-huh.
So what are your thoughts? And then if not those type of tests, what screening tests should primary care providers be doing at ACE?
Right, so are we talking about tests for cardiovascular disease, coronary heart disease, or, because let me tell you a test, what's not included in that. Any cardiologist will tell you that the first test to determine what are everyone's chances of walking out of that door and having a heart event within the next 5 years. There's a test. It's called a pooled risk equation score. Write it down. Pooled, P-O-O-L-E-D, because y'all can test me to know if I know what I'm talking about. Your pooled, P-O-O-L-E-D, pooled risk equation score. All right? It was formerly known as the Framingham Risk Score. Aha, everyone's like, ah. Yeah, we've updated that now, all right? That looks at your risk factors, and it tells you what are your risk of having an adverse event. And if you're above a certain percentage, 7.5 is that percent, you need to be on statins, cholesterol therapy, a baby aspirin, and then you have to go see a cardiologist to either get a stress test. If you're having leg symptoms, ultrasounds of your legs or an ABI. If you're having stroke-like symptoms, you know, and they feel a carotid bruit on physical exam, get a carotid ultrasound. That is the score that determines. Those $99 groupings, to me, they're gimmicks because everyone could do them, but that's not a comprehensive cardiovascular exam. That is, the screening tests have not been recommended by the U.S. Preventive Service Task Force, which is the body that recommends things for screenings like mammograms and x-rays. Those are not included, so I can't put my license on that. Yes, ma'am. So your pooled risk equation score, and if you think that score is high, it does not pertain to people below the age of 40. So if you're under 40, it's know your family history, and if you have any symptoms. If you're over the age of 40, you can use that. Other questions? All right, I'm done.
All right. Give it up for Dr. Thackray. Can I have your